sleep technology is shifting gear towards newer therapies, the newer modes of intervention, but also the newer modes of diagnosis or diagnostics. Sometimes these patients will show as obstructive, and then eventually, when they're on CPAP, they show some central. What are those patients? What do you call those patients?
Like sleep apnea.
Complex sleep apnea. Very good. Or what's the other term? TEXA. So CompSA or TEXA is the same patient. Now, the other thing is that's showing up now are they call them COMISA, or it's not CompSA, it's COMISA, complex insomnia. Some patients who are using the PAP device, they can be compliant. And then they start to have issues falling asleep in the beginning or in the middle or later in the night. So these patients are now developing complex insomnia. And that's hard because these patients then will become symptomatic again the following day, even though their AHI might be controlled or low. All right.
Mm.
So those patients are called complex insomnia or COMISA. CPAP is not always for everybody because some patients will exhibit a cardiorespiratory arrest or they'll have some cardiac issues. Now, it will only exacerbate when given a CPAP machine. What type of disease will exacerbate if you give them CPAP? So what type of disease will become exacerbated if given CPAP? So Cheyne-Stokes respiration. Typically, pneumothorax, yes, you cannot give patients PAP therapy when they have pneumothorax because you'll just increase the thoracic pressure and that can just exacerbate pneumothorax. But if your patients have central apnea or they have Cheyne-Stokes respiration, and if you put them on PAP therapy, they will get worse. They will get worse. That's why it's not applicable for them to use PAP therapy. They need to use ASV, all right? If they have Cheyne-Stokes respiration, they need to use ASV. And you don't put patients on PAP if they have bolus, lung disease, severe nausea, vomiting. So this is important because patients that have nausea and vomiting, what can happen to them if they're on PAP therapy? Yes, aspirate. They will aspirate. Exactly the word I'm looking for. That's why you're not allowed. And trauma to the face, of course, even on the airway, they cannot be given PAP therapy. Especially on the face, where are you going to put the mask? Everything has to touch their skin, even if it's pillows. So these patients might sometimes the only way is to put a stoma, all right, or a tracheostomy. Bilevel and IPPV, right? When do you decide to use spontaneous versus spontaneous time? Give me a reason when you will use spontaneous time versus spontaneous mode. What's the importance of ST mode? Why would you use an ST mode versus S mode?
Backup rate, sir.
Very good. Backup rate. Why? So if you're going to need a backup rate, what's the backup rate for? Why are you putting a backup rate? Is it because of obstructive or central apnea?
Central.
Yes, because they have central apnea. However, the central apnea cannot be 50% or more of the total apneas. That's a requirement now to use a what kind of machine if they have an apnea index of 50% or more.
ASV.
Correct. Very good. ASV na. So if less than 50%, then you can use ST mode. All right. Now, the indication for bilevel is the same as the PAP therapy, of course. But usually, if they are non-compliant with CPAP, then you can use bilevel spontaneous mode. What's the other mode that you can use with non-compliant OSA patients? What is the other types of patients, or what's the other type of mode that you can use with non-compliant CPAP patients? What do you think? Pag ang pasyente, they just can't tolerate CPAP. And you use an APAP. What other mode can you use? So the other mode is auto bilevel. Auto bilevel. You can use that for non-compliant OSA. Okay, very good. So now you have indications for bilevel. Of course, you guys answered this. Overlap syndrome, OHS, Pickwick syndrome, pretty much the same because they have retained high CO2 because of the lower obstructive lung disease. And also they have decreased SpO2 or hypoxia. That's when you need to do bilevel. Because say bilevel, you don't only open up the upper airway, you ventilate the patients, right? You ventilate the lower airway. So what that requires is bilevel device, not a CPAP anymore. The CPAP only offers one pressure, and bilevel can offer two. One to open up the airway, the other one is to provide ventilation or ventilatory support. And which is the EPAP or IPAP. Then you need bilevel therapy also with neuromuscular disease patients. So some of them are your kyphoscoliosis versus regular scoliosis, right? Typically, your scoliosis is lateral, di ba? Ano ba yung pagkaiba ng kypho versus regular scoliosis? So, ang sa kanya is instead of sideways, it's actually front to back, right? Kasi ang scoliosis is tabingi. It's the vertical. So it typically looks like hunchback. Very good. And why would you put patients with chronic pain disorders in bilevel instead of CPAP? Why? What do patients do when they are in pain? What kind of medicine do they take? So if your patient has chronic pain, they will take pain meds, correct? And typically these pain meds are what?
Narcotics.
Yes, narcotics, or the other term is opioids, right? So when the patients use narcotics or opioids, they are more prone to having ventilatory collapse. And not just upper airway collapse, but also ventilatory. Kasi it affects the entire respiratory system, right? When you suppress pain, you suppress respiration and becomes dull, right? When you stop breathing, so your CO2 will go up or down? Up, right? So once your CO2 goes up, the brain understands that. And so when CO2 is already at 47 millimeter of mercury, which is a little bit too high, the brain will say, hey, it's time to breathe. Get rid of this CO2, it's getting too high. So the brain then will enact and then make the diaphragm contract. When the diaphragm contracts, it opens up the lungs, and then you'll take in more air. So then that will wash out your CO2 and will also improve your O2. So that's the dynamics of why do you need bilevel with pain disorders, because when you affect the pain receptors, you also dull or put a barrier into the respiratory drive, right? Parang nagiging manhid siya na sensitivity when it comes to CO2, O2 changes. The pain receptor is in the same area as the respiratory receptors. Make sense? So we're doing a lot of whys. All right, ASV central. Okay, ASV is the last resort. We don't just do ASV immediately because ASV is a totally separate discussion or PAP mode. It's not always the immediate call to get into ASV simply because there are guidelines when you can use these devices, particularly with CompSA or TAXA patients only, okay? So you don't just put ASV when there's a patient that has sleep apnea. Okay, you have to justify that. Any questions? We already discussed change dose respiration, complex sleep apnea, or TAXA. Now, why would you not put people who have chronic hypoventilation or COPD and or restrictive lung disease on ASV? Why? Exam question. Any ideas, thoughts? So if you have ASV, but then your patient has COPD or chronic hyperventilation or neuromuscular disease, why would you not put the patient on ASV? It's a contraindication. So if you think about it, ASV now is different from a regular bilevel spontaneous mode, right? It's very different. For one, when you have a constant pressure support, so let's say, give me a bilevel setting.
Ano,
Random. Yeah, just give me a bilevel setting. 1410 means you have a pressure support of
4.
4, right? So that pressure support of 4 is constant. It will not change whether the patient needs that pressure support or not. So it will always give the patient 14/10 with a constant pressure support. That pressure support will equate to a volume, right? So that 4 centimeters of water pressure, let's say 1 cm H2O is equivalent to 100 ml or 100 cc. So if you have a pressure support of 4, that volume is around 400 ml, right? Or 400 cc. It could be more, it could be less. The point here is that pressure support equates to volume. Hindi ba?
Yes po.
So when you have a constant volume and your patient is on ASV, right? Or that your patient has central apnea or Cheyne-Stokes respiration, when they get a constant pressure support, it will not treat the crescendo decrescendo pattern. And the reason for that is because when you put the patient on a constant pressure support, it doesn't allow for the hyperpnea to be counteracted. Okay, let me explain it in a graphical form. Does that make sense or no? Can you see my screen or no? I wanna make sure that this is like completely hashed out. So let's go to ASV. Okay, so now let's talk about Cheyne-Stokes. Crescendo, decrescendo, central. So if this was the patient's breathing pattern, right? And you're giving this patient a, let's say, 14/10, right? This is your bilevel. Okay. But if this is your pattern, how do you think this will synchronize with the patient's breathing pattern? It will be very asynchronous. At the same time, if you think about the patient's own pattern, sa loob nitong breath is what? What is this inside the breath? This is what? What do you think is inside this breath? This is tidal volume, hindi ba? So the tidal volume on this Cheyne-Stokes respiration, is it constant or not? No, it increases, then it decreases, then they have a central. Right? I'm putting red. That's the volume of air that the patient is breathing with their Cheyne-Stokes respiration. And so if your device is giving a constant volume, if the patient is having an event, an apnea, or very low volume, so this device can give that patient the volume that they need because they need it at this area of the Cheyne-Stokes. Okay, so that volume from a constant pressure support is something good. However, dito sa the patient has a pretty high volume, right? So if you add more volume, what do you think will happen to the patients? That's a question for you. So what happens to the patient? So remember, if this patient is breathing, papalaki yung volume niya, right? And then papaliit. This is the patient's volume. This is the patient's own tidal volume. Hindi ba? Now here, kung ang bilevel mo is constant na 14/10, then okay, that will fix it, right? They will counteract the central or the hypopneas. On the area where the patient has enough tidal volume, and then you add additional tidal volume, then this will cause the patient to have an increased tidal volume. All right. So what will end up happening is in this part, they will be overinflated. Hindi ba? Does that make sense? So if you have a device that constantly gives the patient a constant pressure support, parts ng chain stokes, you will just overventilate them. On the parts they are having some hypopnea, even if it's central, yeah, that's fine because the device will give them a volume of air. Maybe that will fix it. Okay. Some of the other parts of their breathing dynamics, they do not require the same amount of pressure support because they have enough volume. If you add more volume to the existing patient's volume, you are overinflating them. When you overinflate the patient, they will have central. So then you will not fix their central apnea. You will actually exacerbate it. Does that make sense? Okay, good. Clear, siguro. Don't hesitate to ask. I want to make sure that you got this algorithm right and the idea behind this ASV. The reason why it works with some patients and the reason why it does not. All right. So if this patient is breathing this way, hypopnea central, crescendo, decrescendo, central, crescendo, decrescendo, central. How you fix this is a device that will, first of all, will just have a minimum pressure support. Okay, minimum pressure support. But then, when the patient requires the necessary support, increase in ventilation, the device that will increase, right, to maximum pressure support. So they will counteract the hypopnea with enough tidal volume, right? And when the patient breathes again, then they'll go back to minimal pressure support. And then when the patient's having events, they will increase their pressure support. So now the result of this is the patient will eliminate the central because they will be ventilated by the device here. So instead of them having a crescendo decrescendo, they will just be constantly having the same amount of tidal volume. Okay, so then the CO2 and O2 will not have a extreme swing. Kung ito O2 to CO2 tsaka O2, they will not go too low, they will not go too high, they will just be within the normal range. Okay, CO2 primarily will be between 35 and 45 millimeters of mercury. So it will not cause a central. The O2 CO2 will be just on the right track. Now, how do you think that VAPS work? Have you any of you that tried VAPS yet? Okay, the difference between ASV is so ASV, you cannot have somebody with hypoventilation. Saba. So let's put here indication. Sorry for my writing. ASV, you need somebody with central apnea, with text or complex sleep apnea. With VAPS, you can have neuromuscular disease. You can have here COPD with central, right? With CSA, all right? You can have obesity hypoventilation here. So you can have hypoventilation patients. So anything that is contraindicated with the ASV can work here. ASV does not have assured volume. Okay? Dito, it will have a target volume. The device will make sure that the patient will meet the right volume every breath. Whereas the ASV will not. It will monitor if the patient is having a central or having an increased tidal volume, but it will not protect them if they end up with hypoventilation. The setting for ASV is only EPAP and then minimum pressure support and maximum pressure support. That's it. There's no way to protect the breath. Whereas in VAPS, you create a target volume. Meron kang target volume. Sabihin mo na, I want this patient to always have 500 ml. So if the patient stops breathing and does not meet 500 ml, the device itself will increase pressure support to always reach 500 ml if this is what you put. If you put 600 ml, okay, the device will increase the pressure support and will make sure that the patient does not go under 600 ml. Whatever you set the patient's target volume, the device will not allow for that machine or that patient to go under that volume target. Whereas the ASV, there is no way you can protect the volume. Okay, the ASV targets minute ventilation, which is your respiratory rate and tidal volume, but it will not protect it from under breathing. So VAPS, okay for hypoventilation. ASV, no hypoventilation, mainly central. Okay, clear na? And these are your major differences when it comes to ASV and volume assured pressure support. I mention this because there's definitely confusion when it comes to AVAPs also, right? Because the patients can be given an assured breath with tidal volume. When you use ASV, you will only use EPAP, minimum pressure support, and maximum pressure support. Auto ASV or ASV auto, you will use minimum and maximum pressure support and minimum and maximum EPAP. So it's very tricky, but yeah, it works. Sa Philips, it targets peak flow. And then ResMed targets minute ventilation. But it doesn't stay on the initial target. All night long, we change our minute ventilation. So the point there is that the device monitors the patient's minute ventilation or their peak flow in a moving target, right? So example, 3 p.m., right? You start the device. So the first 4 minutes, 3 to 4 minutes, say 3:03 or 3:04, right? The first 3 or 4 minutes, nangola SV mo ng pattern, whether it collected minute ventilation or peak flow. Alam na niya yung pattern ng patient. I will look into this patient minute ventilation from now on and will not allow the patient to drop beyond 90% of their own minute ventilation. So, for example, yung pasyente mo, your device monitored your patient. The patient has a minute ventilation of 8 liters, right? So then the device will know 8 liters per minute ventilation. The 90% of that is what? 7.2 siguro, right? 7.2 liters, around that. So meaning to say, the device will allow the patient to fluctuate, bumaba man ng 7.5 or 7.3, it's okay. It will not change anything until the patient drops below 72, right? That's how it looks at it. It will monitor now, oh, wait a minute, this patient is not meeting their minute ventilation. I will need to support this patient by increasing my pressure support. The auto ASV is not just the minimum pressure support that it will increase. It will also increase EPAP on its own, yes. But the EPAP, typically, it monitors the upper airway blockage, whether it's snoring, flow limitation, or obstructive apnea. It will monitor that. Okay, so it's very sensitive.
Okay po.
Okay, good. VAPS. You will also set minimum and maximum pressure support. You will also set EPAP. However, you will also add a target volume, right? You also set ideal body weight. You will set this patient cannot have a volume under So, right, if this patient goes under 500 ml of breath, then the device will increase. Okay? And sa ResMed, not only will it increase in pressure support, it will also increase in respiratory rate. So respiratory rate is all automatic. Okay? Particularly IVAPS ng ResMed. It will automatically increase the respiratory rate, not just the volume. Okay? So any questions so far? Is this helping you? Sa IVAPS is, first of all, target. Ng IVAPS with ResMed is alveolar minute ventilation. Okay? Philips, Respironics, target niya ay tidal volume. Those are the two main difference. But still, you're talking about volume. It's pretty much the same. And the difference is, sa ResMed din, meron silang auto respiratory rate. So it's not only the pressure that increases, but also the rate. Imagine you have another device, ST mode. The rate doesn't change. It's the same. It serves its purpose, right? Constant pressure support, constant IPAP, EPAP, and constant respiratory rate. The ASV, it has dynamic respiratory rate. So Philips, you have to set the rate, or you can put it at auto. But it varies in pressure support. It changes pressure support. It can go from minimum to maximum. So VAPS, not only can the pressure support change, you also have a device that monitors alveolar minute ventilation or tidal volume. Okay? This is not an easy topic. That's why we're going to keep going back to this until we hash it out. Now, when it comes to titration, the most important thing is to verify if the doctor really wants that. Do you recall standing orders? What do you mean by standing orders? Yeah. However, ASV and VAPS, they both require really long titration. The patients that you serve with ASV and VAPS are very sensitive to pressure, very sensitive to IPAP, EPAP, because they have a compromised respiratory system. You have an increased loop gain. That's what you call loop gain. Signal from one area to the next is not fast, and there's a lag, then you have high loop gain. But if your signal is so fast, it gets to the appropriate area quickly, that means you have a short loop gain. Okay, so it's very quick to respond. So now the doctor's orders is very important because if you don't follow the doctor's orders, the patient might actually pay for this study themselves. Maaring magkaroon siya ng insurance kasi hindi doktor. When you send these things to the insurance company, they will ask for the doctor's order, they'll ask for the patient's summary, then they'll ask for the documentations. And those documentations are very important to attach to the entire application for the insurance company to pay for the device or for the patient's test. Okay? Any questions? Let me ask you another question. What is the range of CPAP machines?
4 to 24.
Good. Let's stop recording.